A very good evening. Myself Dr. Ramyasree. I'm an Afghan educator for NEET PG categorization. So I hope I'm audible and visible. Right. So I am audible now. So welcome to the platform of Unacademy. So in Unacademy, you have the Plus subscription. That is where you have the daily live classes, structured courses, live tests and quiz, and you have unlimited access on the Unacademy, right? Okay. And you can use just a code of OBG. You can use a code of OBG for subscribing to any of the courses of Unacademy and to get a further 10% discount. You also have iconic subscription where you have both Unacademy as well as Prep Ladder, right? So where you again have live classes and batch courses, video lectures and question banks, live tests and quiz and rapid revision courses. So I also take free live classes on the Unacademy NEET PG where you can have the interface of the app, a feel of the app, and every day I'm taking the free live classes on the Unacademy NEET PG at 10 p.m. So today on the Unacademy NEET PG category on the learning app at 8 p.m. I have quick LMRP for FMGE students, and at 10 p.m. I have image-based series. So where I'll revise all the images at one place, where I'll revise all images at one places. Okay. This is on the YouTube. This video is on the YouTube. Whatever video you are watching now is on the YouTube. But these videos, that is 8 p.m. LMRP for FMG students for Gynec, is on the Unacademy Learning app, and 10 p.m. image-based tests. Now, how do you access my videos on the Unacademy Learning app is, you have to download the Unacademy Learning app, and once you download, you have to go to this category of special classes. So special classes are free accessible to you, okay? And under special classes, once you start searching, you can search my name on the Unacademy app to find my classes. My name is Bezugam Ramyasree. Bezugam Ramyasree. Okay. Right, I appreciate Rohit's enthusiasm, and welcome to the class, Rohit. I understand you are a first year MBBS student, but Rohit, this is a quick revision program which is mainly designed for those students who know OBG. So OBG comes in the final year, or from third year you can go on with the OBG. First year is very important. So have strong basics in your anatomy, physiology and biochemistry, so that your throughout everything will be, all other years will become easy for you. So go read anatomy to the full extent, go read physiology to the full extent, physiology, read Ganong, Guyton, every possible book. Biochem, which is difficult, also make it strong, okay? So yes, let's come back. So we have been doing the series where we are going on where we are doing MCQs every day. So let's continue with that. So I'll start with the MCQs and you can keep answering and we'll discuss about it. Okay. So let's start with the first MCQ. Which is the first to be lost in magnesium sulfate toxicity? A very important question, and yes, many times repeat. Which is the first to be lost in magnesium sulfate toxicity? Excellent. So patellar reflex is the first to be lost in magnesium sulfate toxicity, right? What is the mechanism of action of magnesium sulfate? Where do you use magnesium sulfate? What is the mechanism of action of magnesium sulfate? Let's speak all that. What is the mechanism of action of magnesium sulfate? Right, you use magnesium sulfate for eclampsia and prevention of eclampsia, okay? Excellent, Dr. Bipin Kumar. The magnesium sulfate mode of action is NMDA block. It blocks the NMDA receptors. It blocks the NMDA receptors. Magnesium sulfate is useful in treatment of eclampsia. I think that every one of us will tell. You can also use this magnesium sulfate for prevention of eclampsia. Do you have any other uses of magnesium sulfate? Any other uses of magnesium sulfate? Eclampsia, impending preeclampsia, agree. Other uses of magnesium sulfate. It also acts as tocolysis. One very important another use is, excellent, Dr. Bipin Kumar, it also causes neuroprotection in preterm babies. It causes neuroprotection in preterm babies by decreasing the incidence of cerebral palsy. So these are some other things where we can, other uses, and also you can use it in when a patient has torsades de pointis. Okay. Right, this I told what is the mechanism of action and where all we use it. Now next, what is the therapeutic range of magnesium sulfate? The therapeutic range of magnesium sulfate is 4 to 7 milliequivalents. 4 to 7 milliequivalents per liter. If I have to express in millimoles, it is 2 to 3.5 millimoles per liter. So basically it is half in millimoles, right? When do we have patellar reflex lost? At what level of magnesium sulfate you have patellar reflex absent? At 10 milliequivalents per liter, patellar reflex is lost. When do we have respiratory depression and when do we have cardiac arrest? So this all, like, you know, once we tell magnesium sulfate, this all should come in a flow, full non-stop flow. It should be like that. So respiratory depression at what level of magnesium sulfate? Cardiac arrest at what level of magnesium sulfate? Respiratory depression at 15 milliequivalents per liter and cardiac arrest at 20 to 30 milliequivalents per liter. Whenever patellar reflex is absent, what is your management? Patellar reflex is lost, so what is your management? You have to just stop, you have to stop the magnesium sulfate till patellar reflex reappears. Till patellar reflex reappears. Yes, respiratory depression, you can also answer it as 12 to 15 milliequivalents. Respiratory depression at around 12 to 15 milliequivalents, cardiac arrest around 20 to 30 milliequivalents. Whenever patellar reflex is lost, stop the magnesium sulfate till patellar reflex reappears. But when you have respiratory depression or cardiac arrest, you cannot tell stop magnesium sulfate. You have to give antidote for magnesium sulfate toxicity. The antidote for magnesium sulfate toxicity is the antidote for magnesium sulfate toxicity is 10% calcium gluconate. 10% calcium gluconate. 10% calcium gluconate. Okay. 2-3 questions more. How do you give magnesium sulfate? I think that all of you will tell it is by your either Pritchard regimen or Zuspan regimen. Pritchard is IM regimen, Zuspan is IV regimen. Pritchard is IM regimen, Zuspan is IV regimen. How do you prepare the loading dose? You know, each one of us, you, me, midwife, everyone should know how to prepare the loading dose of magnesium sulfate. Why each one of us should know how to prepare the magnesium sulfate? See, I remember it as like, you know, only MCQ wise. but I don't know how to prepare a loading dose of magnesium sulfate. That's horrible, because you 100% should know how to prepare the magnesium sulfate loading dose. Why? Because it's a life-saving drug. Not only we, even we train the PHCs, midwives, everyone also to know how to give the magnesium sulfate loading dose, because it's a life-saving drug. Manu, I have a patient of eclampsia in a rural place. Till I send her to higher center, at least I give the loading dose, she'll be settled, and then I can transfer her to the higher center, right? So we should all know how to prepare the magnesium sulfate loading dose. So loading dose of Pritchard regimen, Pritchard is IM, Zuspan is IV. Pritchard में it is 4 grams of 20% magnesium sulfate IV, slow IV over 10 to 15 to 20 minutes. Zuspan is also 4 grams of 20% magnesium sulfate IV. Pritchard, it is plus 10 grams of 50% magnesium sulfate IM, 5 grams in each buttock. How do we prepare it also, I'll tell you now here. Usually the ampules which we have for magnesium sulfate are 50% weight by volume. That means 50%, 1 gram of magnesium sulfate is present in 2 ml. 2 ml of ampule contains 1 gram of magnesium sulfate. So that is called as 50% weight by volume. Now here I want 20% dilution. I want 20% of dilution, but I want 4 grams. So if I want 4 grams, I'll take 8 ml. But if I give 4 grams ka 8 ml, it is 50% dilution. But I have to make it 20%. So to this 8 ml, I'll add 12 ml of normal saline. To this 8 ml, I'll add 12 ml of normal saline. So what happens? This becomes 20 ml. 20 ml में you have 4 grams of magnesium sulfate. So 1/5. 1/5 is nothing but how much is the dilution? 20% weight by volume. 4 grams are present in 20 ml. 4 grams in 20 ml is 1/5. 1/5 means 20% weight by volume. Okay. So loading dose, how are we giving? We give 8 ml, we add 8 ml of magnesium sulfate to 12 ml of normal saline, and that entire 20 ml I'll give it slow IV. But for 10 grams, this 10 grams, do I require to do any dilution? No, it is a 50%. It is available also in 50%. 5 grams in each buttock, matlab kitna ml in each buttock? 10 ml injection in each buttock I have to give. Okay. Maintenance dose. So that was the loading dose. Maintenance dose is 5 grams in each buttock IM every 4 hours. 5 grams in each buttock IM every 4 hours. Whereas Zuspan regimen, you load the entire syringe with 50 ml. So that contains 25 grams. And then you keep it as a slow infusion pump of 2 ml per hour. Then you keep it as 2 ml per hour infusion. Okay. And how long you are going to continue this? 24 hours after the last attack or 24 hours after the delivery, whichever is later. Now this is basic, all of you know this. Shall I go one step ahead and ask you some more questions which are like, a little thoda extra edge. Okay, as you are attending my class, let us take the extra edge now. I'll be happy if you are able to answer this extra edge also. What is the trial which has told that magnesium sulfate is the drug of choice for eclampsia? What is a trial which has told yes, magnesium sulfate is the drug of choice for eclampsia and it is truly beneficial? Anybody can name the trial name? Okay, second question. Excellent, why Anusha? Wonderful. The trial which has told magnesium sulfate is the drug of choice for eclampsia and proven beneficial is MACP trial. MACP trial. What is the trial which has told that magnesium sulfate is neuroprotective? What trial has shown that magnesium sulfate is neuroprotective? So first answer I got from Anusha. Let's see who will answer the second question. Third question, what are the contraindications for magnesium sulfate? Where you should not give magnesium sulfate. Absolute contraindications for magnesium sulfate are myasthenia gravis. You should not give it in myasthenia gravis and chronic renal failure. See, mild acute renal failure, mild renal failure mein you can halve the dose and give the magnesium sulfate. But when they have chronic renal failure or myasthenia gravis, you cannot give magnesium sulfate. So what is the drug of choice for eclampsia in these patients who have myasthenia gravis and chronic renal failure? That is my third question. So I have 3 questions here which you can answer. I'll give a minute. If you can try, you can answer. Otherwise, I'll let you know. Okay. No, Manoj. So patients with myasthenia gravis and chronic renal failure, drug of choice for them for eclampsia, always magnesium sulfate is best for eclampsia. But as in these patients, I cannot give magnesium sulfate. I have to choose an alternate for these patients. And the alternate for these patients is diazepam. Magnesium sulfate is neuroprotective has been told by the trial named Beam's trial. So this slide is like, extra edge. Let's go back to the next question now. A 32-year-old female with diabetes visits the antenatal clinic at 6 weeks of amenorrhea. She has not been on any treatment. What is the first step in the management which you would like to do on her? So basically, a patient has come to you at 6 weeks of amenorrhea. So what is the first thing which you want to do? And she is a diabetes. So when a patient has diabetes before pregnancy, what do you call that as? When a patient has diabetes before pregnancy, what do you call it as? You call it as overt DM. So you have an overt DM patient coming to you at 6 weeks. What is the first step you want in the management? Or what is the first investigation which you would like to do on her? Do you really start her on insulin? You don't know what is her glucose control, glycemic control or anything, and you put her on insulin? No, you cannot put her on insulin without knowing what is her glycemic control, right? Excellent. The first investigation which I want to do on her is perform HbA1c. Why is it important to perform HbA1c on her? Because HbA1c will give me her glycemic control for past 3 months, and if there was an uncontrolled hyperglycemia, patient has free radical injury and can cause teratogenesis. So it can tell me the status of teratogenic effects in patients with overt diabetes. It will tell me the status of teratogenic effects in the patient of overt diabetes, right? So if HbA1c is less than 5.6, excellent. But if HbA1c is more than 5.6, it increases the risk of teratogenesis. But if HbA1c is more than 10, you have 25% risk of congenital malformations. You have 25% risk of congenital malformations. So to assess whether she is at a risk of congenital malformation or not, I ask her to do a HbA1c. I ask her to do a HbA1c. And one more point is that as she has 25% risk of congenital malformation, what is the best thing you will tell her now? Mano, I have done HbA1c of this patient and it has come 10. So you know that she can have 25% risk of congenital malformation. So what is the advice which you give to the patient? For this advice only, this is the first investigation which you are supposed to do. You can offer her termination. You can offer her termination. I'm not telling terminate, but I'm telling you offer termination. Matlab, you tell her you have 25% risk of congenital malformation. I feel better you terminate and have a proper glycemic control and come back again with pregnancy, right? So when HbA1c is more than 10, you can offer termination. Okay, right. What is the most common congenital malformation associated with overt diabetes? Again, these are like fatafat answers. Full, you have to like be quick. Most common congenital malformation with overt diabetes is? No, Dipesh, you are doing a silly mistake. So most common congenital malformation with overt diabetes is VSD more than neural tube defects. VSD more than neural tube defects, right? When will your answer be sacral agenesis, correct? When my question is what, then your answer should be sacral agenesis. Most specific anomaly associated with overt diabetes. Most specific anomaly associated with overt diabetes. Then your answer should be sacral agenesis. Then your answer should be sacral agenesis, right? Okay. And one more single liner we have here is, so most common congenital malformation is VSD and NTD. Most specific is sacral agenesis. Most specific cardiac anomaly is transposition of great arteries. Right? Okay. And I wanted to ask you one more point here. As these overt diabetes patients have so many risk of congenital malformation, what are we supposed to do during their antenatal management? During their antenatal management, you have to do a 20 weeks targeted scan, that is TIFA scan, targeted imaging for fetal anomalies. At 20 weeks, you are supposed to do targeting images for specific anomalies. It's also called as level 2 scan. Namaste, Namaste Abhishek, Koop Balo. So again a same question, almost a same question. Most sensitive screening test in diabetic mother for assessing congenital malformation is maternal serum AFP, blood glucose, amniotic fluid AFP, HbA1c. Excellent. It will be HbA1c. It will be HbA1c. So as I just now told, here and this question and the next question both have the same theme. So most sensitive screening test in diabetic mothers for congenital malformations is HbA1c. So any over diabetes mother comes to you in the first trimester, first do HbA1c, and depending on the HbA1c you have to decide her further treatment. Okay. Next question. A nulliparous woman with dichorionic diamniotic. Okay, I don't want to do this question. When aspirin is used to reduce the risk of preeclampsia in women at high risk, at what gestational age should it be commenced for maximum efficacy? So we all know that aspirin is used to prevent preeclampsia, which they only told. That was the MCQ which we all know, right? So aspirin for prevention of preeclampsia, proven beneficial are two things. One is aspirin. Another is calcium in patients who are deficient Okay, so the two proven beneficial to decrease the risk of preeclampsia are aspirin and calcium. So when aspirin is used to reduce the risk of preeclampsia in women at high risk, at what gestation should it be commenced for maximum efficacy? So I am indirectly asking you, when do you start aspirin? Is it for this question only the answers are coming? Yes. So very good, Shweta, Aisha. You have to start at 12 weeks. So you start at 12 weeks and continue throughout the pregnancy. You start at 12 weeks and continue throughout the pregnancy. Okay. A woman is noted to have low-lying placenta at her 20 weeks anomaly scan. A woman is noted to have low-lying placenta at her 20-week anomaly scan. At what gestational age should you arrange the next scan to assess the placental localization? Okay, right. So basically in this question, low-lying placenta is placenta within 2 centimeters from the internal os. At your first visit, if you see a low-lying placenta, I'm not much worried. Why? Because first 12 weeks mein you don't have the upper segment and lower segment formation at all. So as and when the upper segment is forming and lower segment is forming, as upper segment goes up, along with the upper segment, the placenta also will go up. So basically it is not like placenta migrating inside the uterus. So uterus only is growing, so along with the uterus the placenta is also going up. Okay. So whenever you have a low-lying placenta, with the hope that placenta and uterus have grown and lower segment has formed, placenta has moved up, I have to repeat the scan again to find out whether it moved or not. So at what gestational age do you repeat the scan to see whether the placenta has moved up or not? Is my question. Excellent, Swati and Jay. You have to recheck at 32 weeks. You have to recheck whether the placenta has moved up or not at 32 weeks. So many of the low-lying placentas can move up. It doesn't mean literally it is moving up. Along with the uterus, the placenta is also going up. Okay. Right, so this is one point you can remember if you don't know, and I see you are answering, that's very good. Next point I'll ask you. Earlier we had a classification of placenta previa as type 1, type 2, type 3 and type 4. Right. Type 1 is low lying, that is within 2 centimeters from internal os. Type 2 marginal. Again type 2 mein you had 2A, 2B. 2B is posterior and dangerous placenta previa. Type 3 is partial. Type 4 is complete. Type 4 is complete or total. Right. Now in this, according to the recent Williams, 25th edition of recent Williams, he removed this classification. He just tells only one thing. Call them as either low-lying placenta or call them as placenta previa. There is no this middle K partial, all that. So low lying matlab within 2 centimeters from internal os. All other, that is marginal, partial, complete, everything he gave only one name, that is placenta previa. Everything he gave only one name, that is placenta previa. Okay, right. So even the investigation of choice for placenta previa is also USG. Investigation of choice for placenta previa is USG. We can never do PV, we should never do PV or per speculum whenever you have a patient with placenta previa, because that will disturb the placenta and they can start bleeding, and once they start bleeding they can go into anemia, complete anemia, right? Torrential bleeding can happen. So we avoid doing PS and PV. Okay, now another point is basic points about placenta previa which should be in your tongue tip, and like fadafat your brain should be answering to you. Placenta previa is a painless bleeding, causeless bleeding and recurrent bleeding. So they start bleeding from first trimester and they go on bleeding, right? But unless until it causes some hemodynamical instability, I'm okay with her minimum spottings, right? Uterus is usually relaxed, but there is chance of malpresentation, and you have something called a Stallworthy sign in placenta previa. Who can tell me what is Stallworthy sign? You can type it there. Investigation of choice is USG. If a patient presents to you before 37 weeks with the bleeding, try to wait on her or expectant management so that she has a lung maturity by giving steroids, and that management is called as McAfee and Johnson's regimen. Beyond 37 weeks, you can go for elective cesarean section by a senior obstetrician with bled, cross-matched and arranged. And where do you take an incision? You have an anterior placenta previa. Anterior placenta previa. Matlab it is down only. Okay. So you are having placenta here. Where should be your incision during cesarean section? Very good. Very good. So Stallworthy sign is decrease in the fetal heart rate on pushing the presenting part into the pelvis. My next question to you is, you have an anterior placenta previa where placenta is lying in the lower uterine segment and you are taking her for cesarean section. Where should be your uterine incision? Will you put Care's incision or will you put classical incision? We still, even though I have anterior placenta previa, I can still put lower uterine segment incision. So probably Mano, if the placenta previa is somewhere here, I'll try to put incision here. But if it is occupying the entire, then also no problem. I put a lower uterine segment incision, I cut through the placenta and then I go extract the baby as quick as possible and I remove the placenta and then suture it. We don't go for classical. We don't go for classical. You can cut through the placenta. That's why I told it should be done by a senior obstetrician who is confident enough and who can be as quick extraction as possible. So you still put Care's incision, that is lower segment transverse incision only. Okay. Next, a gravida 2 para 0 living, a gravida 2 para 0 plus 1 molar pregnancy is diagnosed with RH isoimmunization. So previous molar and I think along with RH. Doppler assessment of which vessel is used to monitor fetal anemia during pregnancy? Right, so I have a question from Aisha ki if expert is not available. Basically Aisha, classical cesarean section is more difficult than lower segment. So while you are suturing back the layers, it is a thick. So there they can, if you cannot make a proper hemostasis. See, most of our the obstetricians which are coming up now, we are not very well trained with the classical cesarean sections. So we are actually well trained with the lower segment, right? But no hard and fast rules in OBG. There are never any hard and fast rules in OBG. Probably if you feel you're not confident enough with the lower segment and cutting through the placenta, it just takes a second. You cut, you go insert, you quickly extract the baby. If it is not possible, then obviously classical. But classical is not preferable neither in the practicals nor in the MCQ purpose. Okay. Right. Okay, after this question, I'll answer other queries which you people are putting for me. So what is the Doppler, which vessel you use for assessing the fetal anemia during pregnancy? Excellent. So I see many of you answering very good. Swati, Demik, Anusha, Mahesh. Excellent. So it is the middle cerebral artery. Middle cerebral artery vessel is used to assess the fetal anemia. Why middle cerebral artery is used to assess the fetal anemia? Because whenever there is anemia, baby does something called as autoregulation. Matlab that brain sparing effect. To the brain, we continue to have the vasodilatation so that the blood is diverted to the brain because it's the most important. But for the liver and but for the gastric and renal, there is vasoconstriction. As there is dilatation of the blood vessels in the brain, if I detect there is dilatation and increased velocity of the blood in the brain, I'm sure that this baby is suffering from anemia, right? So to check for the increased velocity of the blood in the middle cerebral, to check for the increased blood flow, we do the middle cerebral artery Doppler. Now, why in the brain we are choosing middle cerebral artery only? Why not other arteries? This is something related to anatomy. I want you people to answer, why are you choosing MCA Doppler only? Why not any other Doppler? Basically, brain sparing, so brain ka blood supply ज़्यादा हो रहा है. Why are we choosing MCA only? Why are we not choosing any other arteries? Everything has a logic. There is nothing just like that. Everything has a logic. I'll be very happy if somebody can answer, why are we choosing MCA only? Because where does the MCA lie? It is most easily accessible. Middle cerebral artery is present. Yes, excellent Bhargavi. So middle cerebral artery is on the lateral side, so it is easy to access. It is easy to access. Very good, because it is superficial and easily accessible. That's why we do the middle cerebral artery Doppler, right? So in middle cerebral artery Doppler, we check how is the blood flow. Checking how is the blood flow is called as peak systolic velocity. Checking how is the blood flow is called as peak systolic velocity. Now so the blood flow has some unit. Like you have a unit for X-ray, Tesla, like same that peak systolic velocity ka bhi unit hai. That is multiples of median. Now you don't require to do full dissection of what is this MOM means. It is the unit given for the velocity of the blood, right? So if velocity of the blood is more, you are happy, or if the velocity of the blood is less, you are happy. So the cutoff for the velocity is given as 1.5 multiples of median. If it is more than 1.5 multiples of median, it means there is fetal anemia. There is fetal anemia. And you have to confirm the fetal anemia by doing chordocentesis. That is, you go take the fetal blood from umbilical cord. On umbilical chordocentesis, if hematocrit is less than 30%, she requires intrauterine blood transfusion. The baby requires intrauterine blood transfusion. Okay? Right. So now I'll take a query. So I was seeing somebody asking me, what is the incision? What is the incision you give for abruptio placentae? Right? So I have a question here. Somebody asking me ki, what is the incision you give for abruptio placentae? So my question to you is, what is the mode of delivery in abruptio placentae? What is the mode of delivery in abruptio placentae? So abruption management again is very important, because it has been asked for FMG students, it has been asked for FMG students from past 2 exams, and it has been asked for students of INE CET as well as mid exams of the AIMS. So abruption somehow has become very important suddenly, right? So abruption में the preferable mode of delivery is vaginal delivery. क्यों? Abruption में you have placenta is separated, तो बिचारा uterus thinks by placenta is separated, it is third stage, start contracting. So uterus is in josh to push everything outside. When uterus is in josh to push everything outside, I will not tell uterus like by chup I'll do cesarean. No, right? So in abruption, the preferred mode of delivery is normal delivery only, except one condition. If you have abruption with fetal distress, only then, if you have abruption with fetal distress, only then you go for cesarean section. Again it is lower segment cesarean section only which is preferred. Again it is lower segment cesarean section only which is preferred. Okay, very good Rohan. Only if there is fetal distress, then only you will do cesarean section. No other condition in abruption you will go for cesarean section. Okay. Next question. A 26-year-old primary gravida with a singleton pregnancy at 23 weeks. Whenever you are reading a question which is a clinical question, in your brain things should be highlighted are primary gravida. The parity should be highlighted. She has come to you with singleton and at 23 weeks. Attends for an ultrasound scan following a small amount of bleeding. So she has little bleeding. It is noted that her cervical length is 21 mm. What is the appropriate management you want to do for her? Think and answer. Think and answer. I don't understand why many of you are answering insertion of Shirodkar suture. Do we routinely put Shirodkar suture? I would have agreed even if you answer insertion of McDonald, but I don't know why you people are answering insertion of Shirodkar. Shirodkar is not done routinely at all. Excellent Harshita, cool. So the answer here should be B, that is expectant management. Why? Again, you have 3 indications for putting a stitch. You have 3. Whenever there is a question on stitch, your brain should interpret among these 3 indications. So the indications for putting a stitch, number 1 indication is history indicated. History indicated is they should have more than or equal to 3 preterm labors or second trimester abortions. History indicated is where they have more than or equal to 3 preterm labors or second trimester abortions. Okay. Second, USG indicated. USG indicated is where they have one previous second trimester abortion plus USG showing cervical length less than 2.5 centimeters between 16 to 24 weeks. Third, emergency cerclage, that cervix is dilated. Emergency cerclage is when cervix is dilated. Now please understand this question. She is a primary gravida. So she doesn't fit into more than 3 abortions. She is a primary gravida. USG is less than 2.5. But I should have one previous second trimester abortion to support my indication of USG indicated. So that is also not getting supported here. And cervix is not dilated. Cervix has become just small. So that's also not supporting me to put a stitch. as it doesn't fulfill into any of the three indications, as it doesn't get fulfilled any of the three indications, I cannot put a stitch. Now many of you are asking, why can't we do tocolytic therapy? Why do you want to do a tocolytic therapy? Did they give you here that she is having contractions? Did they mention that she is having contractions? The role of tocolysis is when patient has active contractions. That too, they should have adequate contraction. When do we call preterm labor is when they have more than 8 contractions in 1 hour, or when they have 4 contractions in 20 minutes. Neither of that is mentioned here. So there is no point in tocolysis. See, they mentioned there is small amount of bleeding. She came to you with small amount of bleeding. She didn't come to you with contractions. She came to you with small amount of bleeding. And this cervical incompetence, is usually painless. It is a painless dilatation, right? So the best answer I have here is expectant management. So what is the take home message here is, any case of cervical incompetence, you should ask yourself, does it fit into my 3 indications? Does it fit into my 3 indications? Karke you have to ask yourself. If it fits into those 3 indications, put a stitch. No means you should not put a stitch. And that too, which is the most common stitch which you insert? What is the most common So the most common insertion is McDonald's insertion. The most common type of cervical stitch is McDonald's cerclage. The most common type of cerclage operation is McDonald's cerclage. So in McDonald's cerclage, what are you going to do is, you're going to take a bite from all 4 quadrants of the cervix and then tie it. You're going to take a bite from all 4 quadrants of the cervix and you're tie it. Very good. It's a non-absorbable suture which we take. So what is the suture material? You use it in the McDonald's? What is the suture material which you take it in the McDonald's? You can take silk, you can see silk, ethylon. Basically they should be non-absorbable. Again at 37 weeks we'll remove the stitch, right? And expectant management means doing a regular scans. So you monitor her by TVS to see whether the cervical length is decreased or same. Which protein is the most important biomarker for the detection of PPROM? Which protein is the most important biomarker for the detection of PPROM? Nitrazine, placental alkaline phosphatase, placental alpha microglobulin 1, placental vasopressinase, placental pregnancy associated plasma protein A. Very good, Suraj Raj, very good. So I see all of you answering correct. So it is placental alpha microglobulin 1, which is an important biomarker for PPROM. Placental alpha microglobulin 1 is the important biomarker for detection of PPROM. Many times it happens to be, we are not able to understand whether there is actual leak or whether it is just some cervical mucus. So what do we do then is, we give the patient something called as Amnisure pad. See, if you have a pool of fluid which is turning the litmus blue or increased AFP, that is different. But sometimes you can't see anything, but she tells there is a leak. So what we do is, we ask her to wear this pad called Amnisure. This amniture contains FMGE1, and you ask the patient to roam around for half an hour and come back. If the amnition is discolored, it means she is having leak, because amniture is an important biomarker and it can detect the amniotic fluid. So if there is a discoloration, then it is definitely your PPROM. So that's one more important point. Again, this is like, a tricky question and a very nice question. What is the usual method of diagnosing placental abruption? What is the usual method of diagnosing placental abruption? Excellent, Dhritarashtra. Yes, very good, Dhritarashtra. Okay, you have changed the name from Shadi Sudha to Dhritarashtra, no? So the usual method of diagnosing the placental abruption is clinical diagnosis. It is the clinical diagnosis. See, if a patient comes to me with abruption, at one instance only I can identify. I really don't require all these tests to tell that this is an abruption. How? So, abruption you will have painful bleeding. So, if she comes to you with the symptoms of with the symptoms of pain, if she comes to you with symptoms of pain, bleeding, decreased fetal movements or absent fetal movements, by here only I feel, oh, this might be an abruption. After that, on examination, you will see patient will be in shock. Further confirmation. Uterus hypertonus. Uterus is contracting full in Josh and it is tender. I cannot palpate the fetal parts. FHR, fetal distress to fetal death. With this clinical history, I want to confirm my diagnosis of abruption. What is the next thing I should do? With this clinical history, if I have to confirm my diagnosis that yes, this is an abruption only, what is the next thing I can do? So I have seen history, she is telling painful bleeding, decreased fetal movement. On examination, patient is in shock, uterus hypertonus and tender. I will do ARM. I will not go for D-dimer or trans-abdominal ultrasound and all. Do a PV, do an ARM, fat karke. When you do ARM, you will see what will be the color of liquor to confirm that this is an abruption. What should be the color of liquor when you do an ARM, artificial rupture of membranes? You will see blood stained liquor. You will see blood stained liquor. When I do ARM, I will find the blood stained liquor. That is how I confirm my diagnosis that this is a patient with abruption. So it is basically a clinical diagnosis. Yes, investigation of choice is trans-abdominal ultrasound, but most of the time, usual method of diagnosis is clinical diagnosis. Okay. Now somebody is asking me, how do you differentiate between placenta previa and abruption apart from pain? So will you all help me to make a chart of differentiation between placenta previa and abruption? Right. So placenta previa is painless bleeding. Abruption is painful bleeding. Next, placenta previa में uterus is relaxed, uterus hypertonus and tender. Malpresentations are frequent with placenta previa. We don't see much malpresentations in abruption, but fetal parts are not palpable because of the excess contraction. प्लेसेंटा प्रीविया में FHR is normal, fetal heart rate is normal. Abruption में you have fetal distress. To fetal death. Fetal distress to fetal death. Okay. Patient is not in shock. Here they are usually in shock. Uterus is equal to period of amenorrhea. How many ever weeks? That much only the uterus will be. But in abruption, uterus will be more than period of amenorrhea in concealed abruption. More than period of amenorrhea in concealed abruption. So those are some of the differentiating features. Yes, on ARM, here you should not do PV. In abruption, if you do PV, you will see blood stain liquor. In abruption, if you do PV, there will be blood stain liquor. Next, so we'll do one last question for today and then end the session. A gravida 3 para 2 is diagnosed with anterior placenta reaching to the os at 20 weeks. What do you call when you have an anterior placenta reaching to the os at 20 weeks? Anterior placenta reaching to the os at 20 weeks is called as placenta previa. Placenta previa, right? Next, history. She has 2 previous cesarean sections. What further investigation would you arrange for her? So she is a case of placenta previa with 2 previous cesarean sections. What is something which is what suspicion which is arising in your brain? So this is a placenta previa with previous 2 cesarean section. Are you worried about something? What is the risk factor? Whenever you have previous LSCS and placenta previa in current pregnancy, both of this act as a risk factor for what condition? Both of this act as a risk factor for what condition? Yes, I see you people answering correct. The answer is A. But why are you answering A? I want you to tell me the reason why are you answering A. Three clues. There are 3 clues. It is an anterior placenta previa. There is previous LSCS. There is placenta previa in the current pregnancy. These 3 are a very strong indicator of some disease which you should suspect in this patient. Any patient with previous cesarean section, I always suspect that complication. To add on, to confirm my suspicion, she also has a problem that is she is having previous LSCS also. No. Yes, Yugender, Deepesh. Excellent, Devraj. So she is at high risk of having morbidly adherent placenta. See, that's in morbidly adherent placenta, whenever you have trauma to the uterine wall, there will be absence of Nitabux fibrinoid layer. There will be absence of Nitabux fibrinoid layer. Due to the absence of Nitabux fibrinoid layer, the villi go beyond the endometrium into the myometrium. So, previous LSCS and placenta previa in the current pregnancy, especially placenta previa in the current pregnancy, always has a strong risk factor for accreta. Both are at very strong risk factors for accreta. So, you should be suspecting in this patient morbidly adherent placenta. As I am suspecting morbidly adherent placenta, how can I confirm that whether there is a morbidly adherent placenta or not? I can do a color flow Doppler at 32 weeks. Anyway, I'll do a 32-week scan to see whether the placenta is migrating or not. Along with that, when I do color flow Doppler, if I see there is increased retroplacental blood flow, it confirms my diagnosis that I am dealing with morbidly adherent placenta. Why do we see morbidly adherent placenta? Morbidly adherent placenta is mainly seen due to absence of Nitabuk's fibrinoid layer. You have three varieties of morbidly adherent placenta. Accreta, increta and percreta. Accreta is adherent to myometrium. Increta is invades myometrium. Percreta penetrates myometrium to reach perimetrium, that is serosa. They have the increased risk of PPH post delivery, right? And this patient, so she is a case of placenta accreta. Okay, how will you manage her? You have done a color flow Doppler at 32 weeks. There was increased retroplacental blood flow. So I have diagnosed this as placenta accreta. How will you manage this patient? Can anybody tell me how will they manage this patient? Harpreet, do you want to try? How do you want to manage this patient? What is the first thing you will do? You will plan for elective LSCS again. First arrange, know her blood group, arrange and cross match 4 units of blood. Arrange and cross match 4 units of blood. Because I have increased risk of PPH, so I have to be ready with blood, right? Then I will terminate, she is only 20 weeks, I will not terminate her at 20 weeks. I will deliver her electives in future whenever it goes beyond term. I will do elective cesarean section for her. Post elective cesarean section, what do you want to do? If placenta is not coming out, what do you want to do for her? In this patient, do you want to put a lower segment incision or upper segment incision? Wonderful, actually. So this patient, let's understand, she has placenta in the lower anterior placenta reaching the os. So it is placenta accreta plus placenta previa, and that too anterior placenta previa. Okay. She is gravida 3, para 2, living 2, G3, P2, L2, and now again she will have a baby, right? So she is a multi. Yes. So this is a patient where I can validly do upper segment cesarean section. Why will I do upper segment for her here? I will do upper segment because once I extract the baby, what am I going to do this to this uterus? After cesarean section, I am going to do hysterectomy. Cesarean hysterectomy. As she is a multi and it's a morbidly adherent placenta, I really don't want to save this uterus. So I will go for post-delivery hysterectomy. So when I'm anyway going to remove this uterus, how does it matter if I put an incision above or down? Above, if you put incision, baby can be extracted fast. You don't require to separate the bladder also. And I'm not going to resuture it, but I'm anyway cutting the uterus and throwing it out, right? Understood? So there is no hard and fast rule for anything. Every situation your answer keeps changing. You have to feel the question and feel like this patient is there with you, and you have to answer accordingly for it. Okay. So that was for today. I hope you all enjoyed the session, and we had a good discussion on many good questions. I'll be coming back again next month with few more sessions like this. Till then, any queries, you're always welcome to ask the queries, and all the best. Keep studying. And all those who are going to go give the exam on December 4th, these next 3 days, keep yourself calm and composed. Don't stress yourself. Don't stress yourself. You know everything. Believe in that, and 100% you'll all get 200, above 200. Okay. And today night from 8 o'clock, 8, I'm going to do LMRP. 10 p.m. I'll do image based test on the Unacademy learning app. Okay. Thank you guys. All the best. See you again. So any queries I have to take before I end the session? So 20 to 32 weeks, usually these previas and all, they won't cause any active bleeding. So you can just ask her to take rest, not to strain herself, not to do traveling, right? So that basic management is more than enough. At 32 weeks, you repeat the scan to see whether this placenta has moved up or not. Okay. Right. I think. Thank you.